Welcome to the deep dive. Today we're tackling something pretty alarming. Maternal health in the U.S. It's worse than any other industrialized nation. The mortality rates are high and actually increasing.
That's right. It's a serious crisis.
And it hits certain groups much harder, what we're calling U3 populations. That's understudied, underrepresented, underreported.
Exactly. We're talking specifically about Black, Indigenous, and rural women. They face 3 to 4 times the risk of severe maternal morbidity, SMM.
So our mission today is to figure out why these disparities, and importantly, how could better data, maybe a smarter approach to it, help fix this?
The numbers are quite stark. Back in 2021, we saw about 12,205 women die from pregnancy-related causes.
Wow.
Yeah, and that was a big jump, nearly 30% up from the year before. Plus, SMM, those really serious complications, affects over 50,000 women every single year.
And for these U3 groups, what makes it worse for them?
Well, it's a mix of things. There's systemic discrimination baked into healthcare, segregation's legacy, plus often higher rates of chronic conditions.
And practical things too, right? Like getting to a hospital.
Absolutely. Geographic barriers are huge, lack of access, long travel times, and we're seeing more rural hospitals closing their maternity wards altogether. That's a huge blow.
Okay, so the problem's clear. It's fragmented, it's unequal. Is anyone actually, doing this better? Is there a model out there? Or are we just stuck with bad data?
Well, the data is a major barrier. The information kind of exists, but it's siloed. Different data sets, no common definitions, technically very hard to link up.
And I read that health data is big business, like worth hundreds of billions.
Oh, yeah. Estimates are around $300 to $450 billion a year. And that actually creates a weird disincentive, right? Sharing data for public good sometimes clashes with the business side.
So profit motives can get in the way of solving a public health crisis.
It can seem that way. Plus, you have legitimate concerns like IPA protecting patient privacy and rules around PII, personally identifiable information. You can't easily just create a big national database with everyone's individual details. Yeah.
Right. And those reports about maternity care deserts, they help, but
They mostly show where facilities are or aren't. They don't always connect that directly to the health outcomes for specific groups of women, which is the critical link we need.
okay, hurdles understood. But you mentioned an international example,
Yes, the Netherlands. They really figured something out. They have a national perinatal registry,
a single registry.
a unified one, yeah. And using that, researchers found something crucial. Travel time matters a lot.
How much time?
They found that going over, say, 20 to 30 minutes to get maternal care was linked to higher mortality, worse outcomes. Seems obvious, maybe, but they proved it with data.
And that changed things.
Big time. It led to national policy changes, real interventions, and their maternal and child health outcomes improved dramatically. Meanwhile, the U.S., well, our maternal mortality rate is nearly 20 times higher.
20 times. Wow.
And we just don't have that kind of comprehensive national data set to drive evidence-based action like they did.
Okay, so that's the gold standard. But given our system, privacy laws, the sheer size, how can we get something useful here? We can't just replicate the Netherlands overnight.
No, probably not. But there is a feasible path for the U.S. We don't necessarily need brand new individual-level data collection, which is, as we said, tough.
So what then?
We can leverage what already exists, publicly available, de-identified, aggregate data. Think county-level information.
Aggregate data. Tell me more. What kind of sources?
Okay, so you take something like HCUP, the Healthcare Cost and Utilization Project. It's got loads of hospital discharge data, including for pregnancy-related stuff. You can even sort it by routine versus high-acuity visits.
Okay.
Then you layer on sociodemographic data, that's U.S. Census Bureau stuff. Add the CDC's Social Vulnerability Index, which maps community-level risks.
Right, things like poverty, housing.
Exactly. And then you pull in data from CMS, Medicare, and Medicaid services to pinpoint where hospitals are and what level of maternal care they actually offer.
But wait, if it's aggregate, county level, can it really capture the specific issues? Like you mentioned a Black woman in a rural area with other health conditions. Doesn't aggregation kind of smooth over those individual realities?
That's a really fair question. And yes, you lose the individual pinpoint, but the power comes from linking these different aggregate data sets.
Ah, the combination.
Right. By combining hospital data, demographics, social vulnerability, and facility locations for a county, you start to see patterns emerge at a population level. You can statistically disentangle the overlapping effects of, say, race, income, and rurality together.
So you can see how those factors interact, even without individual names.
Precisely. It protects privacy, but still lets researchers understand these complex interactions that drive disparities. It helps identify the root causes so we can target interventions more effectively.
Okay, that makes sense. It sounds like a powerful workaround. So if that's the solution, what needs to happen to actually build this linked data set?
It needs a push, concrete steps. First, get more states to share their HCUP data publicly, maybe even require it.
Make it standard practice.
Yes. Second, we need workshops, bringing state health departments together to agree on common data elements so the data actually can talk to each other, interoperability.
Got it. What else?
Funding. There's something called the Open Data Act that basically says government data should be accessible. But the mandates in it, they're largely unfunded. We need Congress to actually appropriate money to make that happen.
Put the money where the mandate is.
Exactly. And increase grant funding specifically for developing these kinds of linked data sets. Finally, incentivize data sharing after these data sets are built so they get used.
It really sounds like a national linked data set focused on these U3 populations at that geographic level is just critical. The potential to improve research, outreach, healthcare delivery, it seems huge.
It really is.
So here's something to think about. How could really understanding that interplay, race, income, where you live, how far you have to travel for care through data like this, how could that change health policy and access right there in your own community? Could it lead to genuinely fairer, better outcomes for mothers and babies?